In Canada and around the world, there's
mute on
focus on measuring and evaluating quality and safety over the past 10 years and in making sense of that information. In 2013, Professor Charles Vincent launched an innovative way of thinking about patient safety and quality measurement, which better supports organizations to measure, monitor, and make decisions about safety from the ward to the board. Since its introduction, Professor Vincent's Measuring and Monitoring for Safety framework has been tested in the UK by the Health Foundation and other users. The framework shifts away from the conventional narrow focus of informing our patient safety decision-making based on past cases of harm and shifts towards a broader perspective of patient safety information, including current performance, measures of future risks, and organizational resiliency. After reviewing the literature from the Health Foundation and papers by Professors Charles Vincent, Susan Burnett, and Jane McCarthy, the Canadian Patient Safety Institute believed that this new strategy for measuring and monitoring safety would yield value in Canada. It aligns strongly with our newest program, Shift to Safety, positioned as the source for patient safety information for members of the public, healthcare providers, and healthcare leaders. To begin this exploration last fall, we sent Ross Baker and team to meet with Professor Vincent and learn from experienced teams in England and Scotland who've already implemented this approach in a community-wide setting at the board level, as well as in mental health, a frail elderly falls reduction program, and a ward-to-board safety alert initiative. They returned energized and enthusiastic about the work being performed in the UK, and we were convinced as they were, and they convinced us that Canadian healthcare organizations would benefit from using this approach. It gives me great pleasure to introduce Professor Charles Vincent, who will speak to you about his framework for measuring and monitoring safety. As you'll learn more about Charles Vincent's framework on our webinar today, we believe you'll become as enthusiastic as we are about using this framework as a tool for leaders, providers, and patients to guide patient safety improvement. CPSI is committed to sharing and learning about patient safety and helping support this journey with you. So welcome, Charles, and over to you.
A pleasure.
Oh, he's silenced. Please, can you take that lock off?
Virginia, am I coming through okay?
You are now.
All right, thank you very much. Well, I'm delighted to be here to speak to you all. And I'm sorry to have a slight disturbance here, just in a moment. Right, we're set now. Apologies. Welcome to the webinar, and thank you all. It's a great pleasure to be here and speaking to you in Canada. And I'm absolutely thrilled that CPSI would like to take the framework and hopefully use it in Canada. And this is obviously the first time that we are attempting to discuss it today. It's also a pleasure for me and maybe helpful to talk to you at an early stage because we've had some experience of using the framework here in Britain, and sometimes there have been some misconceptions. And I've been to speak sometimes halfway through a program and found that people had not really been introduced to it in quite not exactly in the wrong technical sense, but not in the right spirit. It's really a conceptual framework, but hopefully with much practical application. So what's really important about this is that, firstly, I think it is important to try and understand it, what we are trying to get at, and which is really to take a lot of the learning and understanding the theories that Ross and I and others have used and try and package it in a way that's useful. Because a lot of the theory is not actually being translated into any format that can be that can be useful in healthcare. But the second thing is, it's very important then to make it your own. These concepts are deliberately quite broad because wherever you work, you have to take these ideas and make them work in your area. So if it's care of the elderly, mental health, primary care, whatever it is, we have found that these ideas are relevant, but you have to kind of make them your own to see in what way it's relevant to you and to create your own measurement and monitoring framework. This is not to abandon the broad ideas, but to work within them. So let me now just talk you through the framework. Virginia, have I got control of the slides, or are you going to have to move them?
You have control of the slides. I'd be happy to move them if you want.
I'm trying to move them, but I'm not having any success.
If you click right on the slide and then use your cursor.
Okay, let me try.
Or the arrow at the top. You'll see at the top of the
screen. Let me try the arrow.
07.
Okay, the arrow's working. Fine. Here we go. So the first thing I want to do, although they've been kind enough to say it's the Vincent framework, was actually done with my two colleagues, Jane Carfley and Susan Burnett. Although I guess I'm more involved in spreading it, but Jane is doing workshops and all sorts of useful things with it as well. So let me just take you back a little to the origins of this and why we felt it was important. I've been interested in trying to measure safety for a long time, and like Ross, we carried out a study in Britain of the extent of harm to patients and found that, as you all well know, about 10% of harm is preventable. And this, to me, not this particular study, but these kind of studies are one of the most critical foundations of patient safety, in that it tells us the extent of harm to patients to some degree and gives us some hints about where it is and what to do about it. But one of the main responses to this was to set up incident reporting systems, which are useful, of course, and we have a huge one here in Britain, which is still running, although our patient safety agency has been abolished. And we have enormous numbers of incidents. And an immediate confusion arose, certainly here, about whether this was measurement. And for many years, and still now, people have taken this as a measure of safety and that incidents are somehow a measurement. But in fact, we have known from some studies that incident reporting is pretty useless at measuring harm as compared with the record review studies, and they don't really detect it. So in our thinking about safety, there's this long-standing confusion. And more than that, we have lacked many years. I think it's better now, but when we were commissioned to do this study about 4 or 5 years ago now, we were still grappling with, well, are we getting safer or not? And how would we know anyway? So this is a paper for us from the BMJ, British Medical Journal in 2008, where we tried to look at some of the progress. And I won't go into this in any detail, but our conclusion from this was distressing in a way. It was not that we were making progress or that we were not. It was more that we couldn't tell. And I think other people have made similar assessments and come to similar views. There are more studies now, but it just shows you how neglected the whole issue of safety measurement had been in the years that we've been working on this, which is probably a couple of decades now for many of us. So when the Health Foundation put out a tender and put forward a commission for a piece of work, Susan and I were very keen to take it up. And I think it's worth saying that the original conception of this was really not what turned out. It was to see what measures are best. You know, could we identify 10 or 12 measures which would tell us whether an organization was safe or not, and allow us to index safety over time. So I was interested to do it, but I was also interested for another reason, which I think is important to us today, which is that I would sometimes go and talk to boards, particularly boards, not only them, other clinical groups, and they would sometimes say, just tell me, are we safe? And I would say, well, you know, you're running a hospital, of course it's not safe. And but this was obviously a very unhelpful response and didn't get us very far. But in exploring this with people and listening to the conversations, what was striking was that there was very little agreement about what this question meant. People would talk about the culture. They say, well, if the culture's all right, then the organization is safe. Other people would say, well, it's about mortality. You know, if we got a good mortality rate, adjusted mortality rate, that's an index for all the rest of the organization. I mean, it seemed crazy to me. Or they would point to other sorts of measures. Or sometimes people would say, well, it's the experience of the patient. That's what counts. Or, well, you know, it's whether our processes run on time and if they're reliable. And the conversation would go round and round and would not really get anywhere in the end, sometimes for a long time. And I didn't have any clever answer to this at all. I had some ideas, but I didn't have a definite answer to give about what this question even meant. So the report, in a way, is an attempt to answer this, or at least to say how one might reasonably address it. And this, I hope, is what we will lead into today. So let me now sketch the report for you. And those who have read it will know that there's apart from the basic concepts, there's lots of examples. And I can tell you that some of the teams here really went into the report and used it in tremendous detail, and a few others, people hardly read it, some of the leaders, which, and understandably, got absolutely nowhere. So let me tell you a bit about what we did. We reviewed the literature, and we looked at the history of the measurement in the NHS and safety measurement and other areas. We looked at the academic literature. We looked at other industries. Jane Carthy wrote a very nice chapter on approaches in other industries. We also looked at the theories, fairly deep stuff, and tried to understand what they were recommending about measurement. And the answer on the whole was very little, except that there was a general sense that just looking at past harm was not adequate. And we did interviews, we did some case studies, and we put it all together. And I'll just say a little bit about the other industries' work, because one of the key things that comes from that is the attempt not to abandon past harm, which is what some of the theorists might advise us to do and think about resilience, whatever it might be. But to say, well, you have these measures of the past, and these are important measures of incident, lost time, injuries, and all the rest of it, accidents and so on. This is critical to monitor this. But they also try and look at other facets of safety, which is leading indicators. Are we going to be safe in the future? I mean, whether these indicators really can predict in any quantitative sense is not always clear. But the attitude is very important of trying to think ahead and to use that as part of thinking about safety, which, as you'll appreciate, is a fairly ordinary experience. For instance, if you're driving a car, you always try to think ahead and see what other people might be doing or failing to do, and what whether it's foggy and all sorts of things like that. But somehow this kind of basic understanding of safety in daily life has not translated into healthcare. And this is one of our purposes, was to doing this. So I want to just also emphasize the shift in our thinking, because I think it may be important for you too. Because we had these various introductory chapters, and then we had to think about what to do next. And as I said, we were originally thinking about, what measures might be useful and coming up with a top 10 or something like that. But in the course of going through all this and thinking more about it, it became clear that this was not really adequate to what we were thinking and what we were finding. And I remember sitting in the same room as I'm in now, actually, staring at the wall and wondering what on earth to do and how to go forward. And then it dawned on us that we had to shift somewhat to just trying to measure things in a concrete fashion. And that this was, as we all know, that safety is a much more dynamic problem. Things can go wrong day to day, and any clinician and people running hospitals knows this. So it's much more a process of inquiry. And we started to think about questions. And what were the fundamental questions to ask if you were going to think about this question of safety, and is your organization safe? And once we turned it over, completely turned it round to thinking, as I came to say later, from moving from what you might call an assurance model of safety, where you try and sort of pin everything down and measure it and say, right, that's sorted, that's safe, to a continual questioning. then you have a different attitude. It's a bit more fluid. It can be a bit unnerving, but it's hugely more productive and more real and more accurate as to the uncertainty of the situation. So the questions for us, has care been safe in the past? Are our clinical systems and processes reliable? Because safety and reliability are not the same thing, but if your systems are unreliable, as many of ours are in healthcare, they're not very likely to be safe. Is care safe today? And again, anyone who's run a ward or a practice or a team of any kind knows how quickly things can go wrong and get into a hazardous state, whether it's equipment falling apart or people or organization or pressures from patients or whatever it may be. Things can change very rapidly. So that's a critical question. And of course, will we be safe in the future? Can we look ahead? And are we responding and improving? This is really about this led us to thinking about how you pull this information together, because doing the things on their own, it's the integration of it is critical. So this led us, these 5 questions lead us into the 5 dimensions that you'll have seen if you've seen anything at all about the framework. And I wanted to have something very simple at the heart of this, because I knew somewhat cynically that if I want to get anything to work in the NHS, I had to be able to fit it on one slide. Now, there's one obvious dangers about this, which is people think the slide is the whole thing and they don't go any further, but it is nice to have a single diagram. And some people have put integration of learning in the center rather than around the side, which I think does make sense. Other people, I taught 5 things to remember was simple enough, but a few have translated it even into past, present, and future and made it even simpler. But I think this is dumbing down and you lose a great deal if you do that. So I'd caution you. I'm not saying that 5 is necessarily the perfect number, but there is something important about all of these elements, and to trim it down too much, you may lose a lot. So what I'll do now is just walk you through some examples of what I'm talking about or what we meant by past harm. But there's lots of examples in the report. The second half of the report is all about, well, how can you look at this in practice? Can we find things? And these are just ideas to look at and use. And obviously you will find your own appropriate ways in your own environments. So harm is an interesting concept. It seems fairly clear what we mean by harm, but when we've done workshops and asked people to spend 10 or 15 minutes in a group just thinking about it, it's incredible what a flexible, a fluid concept it is, and how people don't agree. And there's not going to be a perfect definition, so it's more a question of agreeing what you mean by harm in your particular environment. Although there's obviously a place for much more standardized definitions when you're doing national studies or something like that. So this is the overall framework. I'm sorry, I missed a slide here. And this is putting the questions against the particular elements of the framework. So I'm going to go on to past harm now, as I said. And we set out just as an example that some of the different types of harm. You have treatment-specific harm, which is something to say with a surgical complication or a side effect from a particular drug. You have general harm from healthcare that can happen to anyone, like falling over, psychological harm. There's all sorts of different areas, and some things you may not feel is really appropriate to include under harm, but this is for you to decide when you come. But here's an example how the harm we sort of take from incident reporting and the ones we think of commonly may not be adequate in some environments. So I used to work with a geriatrician, care of the elderly physician called Susie Long, and we worked together on her PhD. And this was about what harm meant when in her patients, the patients she looked after, older people. And Susie said, well, of course, we have all these harms. I've read the papers and I've seen what they have, and that's true. That happens to my patients. But we have an awful lot of other things that happen to us on our wards, and these are some of them. Pressure sores, okay, that's a more general one. Incontinence, but delirium, depression, these are things that can come on as a result of poor treatment within a hospital, and people actually decline. So when you start to say, well, what does harm mean in this environment, the definition expands in a way that perhaps is not immediately obvious. And this is going to be true probably in mental health or in other types of environment. And of course, what you want to measure in these different environments is again going to be different, and will probably be different at different levels of the hospital, whether you're at a board or on the ward or running a clinical directorate. So that's an example, just a general sense of fleshing out what harm means. And we also have to do the same kind of thing with reliability. So let's take an example here of one aspect. Now, there's very many different facets of this, and I would say that defining what reliability means in your environment, which people find surprisingly difficult, but it's saying not everything can be reliable 100%, it's just not feasible. So it's a question of what is absolutely critical to you in your environment, both in terms of delivery to the patient and underlying systems. And give an example from Atlantic Systems. This is a study by Susan Burnett and colleagues of mine and myself, looking at reliability of basic systems in NHS organisations. I'll give you one example, a fairly alarming one if you're thinking of having an operation. But I've shown this information to people in many countries, and the surgeons just nod and say, yes, that's how it is. And this is the amount of missing and faulty equipment. This is at the start of operations. This is 500 operations we checked. And as you'll see, about 20% of the time, a fifth of the time, the operation starts with something missing or something faulty. It's quite incredible as compared with almost any other industry. And of course, there are many reasons for this, and we could talk about it a lot, but it's an extremely common experience. So the underlying reliability, and if you take a nice quote from this surgeon, it's just the people are so used to it, they've lost hope of trying to sort it out. But you can see most of the time this is not going to matter to the patients, and the reliability, the team will adapt, they'll get round it, they'll wing it. But clearly, it's not as safe as it might be. So reliability is very, very critical. So let's come on to the next one round the circle, which is sensitivity to operations. Now, excuse me. This is a difficult term, and we chose this term because largely we couldn't think of anything better. But it does, once you get to know it and get to understand the reasons, it will hopefully make sense to you. And you can call it something else if you wish, if you're in your own environment. But I would say it's worth trying to understand why we use this term. And it comes from the high reliability literature. And the people who studied nuclear power plants, aircraft carriers, and all sorts of other settings, organized places where safety was constantly compromised, but somehow they made it work. And the image that particularly comes to mind is the guys on the flight decks of aircraft carriers who are standing there monitoring what goes on, making signals to the pilots and other people, standing in the thick of it. And they have what is sometimes called situational awareness. They know what's going on around them. And they have to know what's going on and just be alert to everything that's going on. So what we were looking for is what would the organizational equivalent of that be? And to give you another image, I often think that the clinicians, if you're sitting at the bedside of a sick patient or if your child is ill, you sit there and you're very alert to what's going on, and you're alert to any sort of sign of deterioration or improvement or minor changes. And again, what we were wanting for is what is the wider equivalent to this, to safety in a team or an organization. So a team leader in whatever circumstance can be alert to the things that are affecting their team, the patients on the ward or in the practice or the department, fatigue, lapses, equipment breaking down, people who are not really working as they should on that particular day, and so on. All this is part of sensitive to operations. It's the operations are the day-to-day processes and things going on, all the activities. That's what the sensitivity is. And if you're a manager, then you have to be alert, again, a similar way to staff shortages, equipment breakdowns, and all sorts of things. But similarly, you're going to have to juggle day to day. And this is a very familiar part of healthcare. But we wanted, if you like, to dignify it and to say this kind of awareness and making space for this awareness is more importantly, is part of safety. And we looked and we tried to think, well, if you accept that this is important, how are you going to do it? And in less pressured times in the past, teams would perhaps meet on a regular basis anyway. They might have a coffee, they might have a break or something like that. And a lot of this would go on informally. Now we probably have to formalize it a little bit more to make space for it. So operational meetings, handovers, ward rounds, briefings and debriefings, they do many things, but one of their functions is to say, okay, how are things going, what's happening now, and to anyway, create space for this monitoring, this safety monitoring. And the use of the word monitoring as well as measurement was again important for us. And does it mean that we extend much more to this day-to-day aspect and this soft intelligence? There are quantitative measures that may be helpful here, like bed occupancy and all sorts of things we might consider, but certainly part of this is talking to patients, talking to staff, and just being alert. And thinking to yourself, well, if I just go on a wander for 15 minutes, I might be seen, looks like I'm not working, but I might pick up more about what's going on than if I sit in the office and read incident forms. So I'm not saying this to rubbish incident forms or looking at them, but just simply to pose this question as to where safety comes from. So let's look at anticipation briefly as well. And it's a similar idea, not completely distinct, but more longer term thinking ahead, I think. And again, to give you an image, we know from my colleague René Armour-Werty's work and many others that a big feature of expertise is thinking ahead. And you might think that fighter pilots, for instance, it's all kind of adapting and being the kind of Top Gun kind of guy and being fantastically good at responding to any threats and so on, which of course they are. But what René pointed out to me and to others, to all of us, and there's many other examples of this in different expertise, is people in these kind of work spend huge amounts of time planning these missions, whether it's in a civilian time or in time of war. And there's a massive amount of preparation. And even during the flight, they're spending a lot of time thinking about what might happen rather than what is happening, and posing scenarios to themselves about how to handle it. So again, our question is not so much on an individual basis, but what the organizational equivalent of this might be. So these are some of the things. The WHO surgery checklist, although it's a reliability tool, if you like, it also contains an element where the team will sit there and say, okay, are we ready? What's going to happen in this operation? Is there likely to be bleeding? They're going to sort of try to predict what may happen in the next hour or two. Longer term things, we have risk registers. I'm not sure if you have these in Canada or what they're called, but attempts to predict. This is, and you might think of safety culture in this sense too, and other sorts of information. This is obviously the least developed in healthcare and in many other settings, and harder. But we feel it's important to build, again, try and build space into this. The final one is integration and learning. And this is basically about how you pull this together. Now, this is going to be different if you're in a small team of 6 people running a ward. It's going to be different from if you're running the whole hospital. But somewhere or another, you have to pull this together. And I was involved in a report made by Don Berwick and a team of people that looked at the British NHS and a review of safety. And this is what he or we wrote here. Most healthcare organizations, little capacity to analyze, monitor, or learn from safety and quality information. I'm not sure if it's true in Canada, but it's certainly absolutely absurd, the situation in Britain, whereas the finance department is enormous and the sort of handful of people are monitoring quality and safety information. And no wonder we don't notice warnings and we have no means. So this is partly a plea for more investment in this kind of activity, but also just, again, to take it seriously and to create space. And we found some examples of teams who did this, and this is just one. I'm sure there are great examples in Canada too to use this. This is Great Ormond Street, a paediatric centre, a world-famous centre in London, and this is some of the some of the groups there, and they have just monthly meetings where they review a whole suite of safety-relevant information. As you see, there's just some examples here. This is described a bit more in the report. And I just want to point out here that some of this is standard quantitative information, infection rates and so on, and compliance, reliability stuff, but also just more softer stuff, themes identified, things people are worried about, conversation. I heard this the other day, I'm worried about this. All that's brought in to this sort of version. And if you look, we can find exemplars at the sort of system level, like Intermountain, which have a huge and complex and sophisticated monitoring of safety and quality metrics, which they can use both, some of which is real time, I think, and some of which is trending over time. So again, few of our organizations here have this sort of system, but we can aspire to this. So that's just a sketch of this, of the report, and it really is a sketch, but hopefully gives you the flavour of it. And I just want to spend 5 more minutes, which I think I've just about got, giving you just a flavour of what's happened since. Just trying to point out a few things that hopefully may be of some use to you. The Health Foundation did fund a very large program a couple of years ago into trialling this with 3 regional groups. I think Health Improvement Scotland, which I know CPSI visited, have done some really fantastic work here. Some of the other sites were also successful, some not so successful. So we've learned a little bit from interviewing people here, and I'll just share 1 or 2 things here, but I'm sure that Ross and others as this program unfolds will be able to share more with you about how it's worked over here. I think the first thing to say is that it's been an extraordinary interest in this report. Quite surprised me and the Health Foundation. And this is not the most up-to-date, but there's been a massive number of downloads of the report. It's still available. You can download it for nothing, and I don't think they stopped giving out hard copies because they thought enough was enough. But anyway, it's available there, and I could give you more figures. And I think it takes time in the programs, but once people get hold of it, and when we interviewed them, which we've been putting this together recently, we did see some quite big shifts in how people thought about safety. And this is just some of the examples about thinking more proactively, broadly. And this, I think, very important thing is this common language. One of the things I learned early on in talking to people about this, and some of the first seminars the Health Foundation on this, where people said, yes, this will work. They said, it doesn't matter if you're on the board, these concepts are still relevant at an organizational level. And if you're running a children's playground, actually, you can think about these concepts the same, but or ward, anywhere, these basic ideas are going to be relevant. Sure, they'll play out differently in different environments, but we can use this commonality of language to say, yeah, we're all talking about the same basic thing when we're worrying about the safety of our organization. But it does take a little time to sort of unpack it. The ideas are not essentially complicated, but as you get to work with them, you see, oh yeah, there's more aspects, there's more to this than I thought. Certainly this was my experience. And here's a nice quote from somebody who really, did some great things with it. And he says, I thought it was a simple framework, which of course it is. But in a way, it's not easy to get it to work and to think about all the aspects. And I don't think it need take 18 months to understand it once you sort of start going into it. But she found it difficult, but once gradually, it all became together. And that's the experience of a lot of people. And I think in CPSI you have an advantage. I think you have a real great understanding of the whole thing, and this can all happen much more quickly because, if I may say, I think CPSI is approaching it in a great spirit, and they understand what it is, what it's about. It's a conceptual model, but it's got these practical implications, and that'll be a big head start. The other thing we learned, again, this is not being clever because people told us that, as I said, it works at different levels. And you can think about this at different levels of the organization, whether you're on the board or elsewhere. And hopefully it will provide a framework that will work across levels and be a sort of shared enterprise. Just a couple more things. The first is, again, a reminder to make it your own. And I've borrowed this slide from Health Improvement Scotland, because they use it in workshops, which is to say, you need to talk about all the concepts and say, and what does this mean in our area? What do we want to be reliable? How do we know care safe is today? And once you've done that in this workshop, and fill in the blank spaces if you like, then start to think of ways, and okay, and how are we going to get that information? Where's the measures going to come from? How are we going to make space? Who are we going to talk to? And start filling it in. Now, these are examples from the actual report, but I'm putting it up to say, well, you can create your own. And finally, just one message which may be more important in Britain than in Canada, I don't know. But we have an extraordinary amount of regulation, performance management, pressure of above, attention to safety and quality, much of which is very good, but it's completely overwhelming. But it has led to this rather absurd situation that when people say, is an organization safe, they say, in effect, they look to the report to the regulators and the people coming around to inspect them. Now, the regulation is important, the inspections can be useful, and so on. But it is also slightly crazy not to look inside your own organization. And what perhaps the most important thing about this framework to me, and I think to lots of people is, and I've come to understand this more in talking to other people, is that it's a shift from what I said at the beginning as an assurance model of, you rely on people coming around to inspect you, to one of inquiry, which means not only creating your own systems in the manner we've been talking about and trying to go deeper by thinking conceptually, not just saying, oh, we've got a list of metrics, we'll have to make do these, but to go more deeply into the whole question about what it means to be safe. And hopefully the framework is a way into this problem that will be useful to you, I hope. And the question comes, again, not so much, are we safe, do the inspectors tell us we're safe, or the regulators are, can we be sure we're safe? It's much more, the safe organizations for me are the ones which are in this process of continual inquiry. And when you read about, say, how safety investigators in aviation and other industries work, they are constantly worried about things. They're constantly saying, well, I don't like the look of that, I'm not sure about that, we ought to investigate that. There is this process of continual inquiry going on, and I think that to me is what will make things safe. So thank you very much. That's a rather long overview, but we agreed before that it was important to try and give as much as I could in the time we had available. So I hope that is useful to you, and I think I will now pass back to Virginia and over to Ross to say a little more about how things are going to go in the Canadian context. And I would just say again, thank you so much for your attention, for being on the call, and I'm thrilled that CPSI is going to use the framework in Canada. It's absolutely marvelous. Thank you.
Thank you so much, Charles. That was just a wonderful overview of the framework. I'd like to now introduce Ross Baker, who's going to talk to us about how this all applies in the Canadian healthcare context. Ross?
Thanks, Ginny, and let me start by thanking Charles for a very clear explanation of the framework and what you've learned about using it, and more broadly to thank you for you and your colleagues for developing this, because I think it is an important advance in the way in which we think about safety and the way in which we integrate safety into daily work. And many people have been concerned in the last few years that the safety efforts are moving much more slowly than we'd hoped a decade ago, and I think your framework offers a real opportunity for us to deepen our knowledge about how to create safer, more reliable care. So I want to just start by just saying a few words about the experience that Virginia and I and Anne McLaren had visiting with Charles and some of the teams in the UK who are using this, and what we learned from that. And I think that it goes back to these issues that Charles so nicely laid out, that the core of the framework is, although we call it measurement and monitoring, it's really about helping people to think about safety in a broader way, giving them a much bigger view about the conditions and the necessary requirements to create safety on a current basis, and thinking forward about how to create a safe environment that's going to assure that the care that people receive is going to help them and not unintendedly harm them. It does lead us from this view about thinking about safety as a past event, as we examine the past, into thinking about safety as something where we need to continue to ask questions about how do we make care safe for the patients we see today and the patients who will be coming to see us tomorrow. Now, that the challenge for this is that it isn't just a pat formula, obviously, and despite the sort of neat boxes in the framework, it requires teams to come together and really struggle with these issues as they move around to identify what the measures are and what the activities are that are going to guarantee safety. So there's a great potential here, but it's a potential that really needs to be aided by creating a learning environment where teams can work together and where they can see the experiences and struggles of other teams moving forward. What we took away from our experiences both in Manchester with a group led by Maxine Power in a collaboration with the Salford Royal Foundation Trust, and in Scotland in groups that Health Improvement Scotland are helping in Tayside and in Borders, the two of the regional areas within Scotland, is that these teams really benefit from this interaction. And so we're thinking about creating a breakthrough series style collaborative to work with teams in Canada to do this. We also recognize how important it is to have people who are familiar with and understand the complexities of this framework, and so it's important to have experts engaged to help those teams move forward, and individuals who can coach the teams to work through the issues about what are the things we want to measure, how do we change the conversations we have as a team, how do we link our understanding about safety at a frontline level to the way in which people are thinking about safety at leadership and governance within our organizations. And we think it's important to work from the front line up, but to also create this dialogue with leaders and trustees in organizations. Now, to do this, we think it's really important to create an environment where people are trying this out, learning, and then also we can assess what may have to change as we adapt the framework to the clinical environments in Canada. We have different structures to boards in this country than they do in the UK, and so I think that's an important difference as well. We're thinking about creating this new initiative in this year, starting in the spring of this year, going for 12 months in a breakthrough series style collaborative with two-day learning sessions and one final one-day session where people come back and report on their learning, and then in between that to have active learning times with on-site coaching for these teams, learning from their experiences, helping to identify what the issues are moving forward. We think the composition of the team should include frontline staff, at least one frontline staff member, a physician lead, middle manager, and potentially a senior manager and a board member, but we're open to discussion about what's the right team from each one of these individuals. We're going to start with a fairly small number of organizations and use that as a basis for building our knowledge about what could work in the Canadian environment, and then to share that more broadly with a series of resources that we develop and other activities to help spread this learning to other organizations across this country in different situations, different types of care, different environments for care. So this is a really exciting, I think, opportunity for organizations to participate. We're looking for organizations who come with an interest in this, who have strong leadership and quality improvement, patient safety capabilities within their organizations, who've identified a clinical program which could be used as a initial focal point for this activity, and who have some resources in their organization to support the measurement and monitoring work at that team level, including some dedicated resources for the measurement and quality improvement activities that I think are a critical part of this moving forward. We're also looking for organizations that are interested in using this as an opportunity for their boards to learn more about quality and safety, and to link that board inquiry, that board understanding to what's happening at the front line. And of course, it's always helpful to have had some experience in engaging in some of these collaborative activities, breakthrough series style, where you're working with multiple organizations who are trying out and learning together these new efforts to move forward. So, as I said, I think this is a great opportunity for us to take advantage of the great work that Charles and his colleagues have done in the UK, and some of the experiences that they've had putting this framework into place. And we see this opportunity to engage with Charles and others to really bring this knowledge to Canada. So I'm going to stop now just so we have a few minutes that people can ask questions and any inquiries that you have about the nature of the framework or how this might be translated into the Canadian environment.
Thanks very much, Ross. And I see we have a few questions, a Q&A box, which we will go through, and then Alex will put up a poll for you to answer before you leave. It's very important for us to get your feedback on this. So let's start with a question from Jignesh Padya, who asks, how long does it take on average to see some clear difference in outcome after the implementation of the framework? Charles?
This is a difficult question to answer, because I don't see, if you're thinking of it as a kind of technique like a surgical checklist or something, then you would expect to see a fairly predictable timescale. You've got a very specific idea in mind. This is much more difficult to evaluate, I think, and also it depends really very much on what the team sets out to do. I would say that you can think of outcome in different senses, though. If you want to say how quickly does it start to shift people's thinking on safety and so that generate new ideas, that can be very quick. I mean, it can be in a single day or over weeks, or certainly. But in terms of, is it going to actually make care safer? On its own, no. It's much more, this is a diagnostic of the system, and it helps you think about how to keep things safe. And as Ross, I think, was explaining, this hopefully will be a foundation for other types of activities. So I'm reluctant to give a kind of specific answer on this, not because I don't think it has an effect, but the effect is going to be more generic. However, it may well lead to specific changes. One of the areas I think that is critical to look at, and which is probably people found hardest, it's which measures are most important. And I think people found it hard, for instance, to start, say, cutting out measures, things that they were already measuring, and putting new measures in place. So this is all much more about how you go about things. And in a way, as I say, it's more of a diagnostic than a treatment. And but I understand the CPSI program is probably going to involve specific interventions for improvement coming out of this as well. But it's a complex question. I'm sorry, I can't really answer it at sufficient length now, really.
Well, I've got another complex one for you. Also from Jignesh. The question is, with programs like this, it's often difficult to implement for a number of reasons, not the least of them being funding or change management or competing priorities. Is there a study that's been done on return on investment and required investment to fund a program like this?
Okay. Let me first stress that this is not a framework that's been in existence for years and years. I mean, the report came out about 3 years ago. The Health Foundation's run one quite big program, Manchester stuff. But CPSI and you in Canada are going to be the people who I think who do a further test of this. I don't think anybody's done any formal studies of this nature. This is relatively early stage, and we're still trying to develop these ideas. I say we, I mean all of us in Ross and Virginia and Chris and the rest of us. I would say that in a way the investment needed is not very large. It's mainly one of time. But the people involved in this, their job is already to think about safety and to take actions on safety. So you're only asking them to start thinking in a different way and to put aside a little time to understand this. So the eventual cost of doing something about this or using this framework is not huge. And it is not really an additional, I think, to, I mean, apart from some learning sessions, to what the organization should be doing anyway.
Thank you again. I'm going to blend two questions here. Question is this framework, is this a framework for improvement, and how is it different from other improvement frameworks? Plus, what would be the burning platform for taking this on?
Okay, is it a framework for improvement? No. And to use it as a tool for improvement is to misunderstand it. It's a conceptual model, and you may think that's too abstract and airy-fairy for you, or you have that phrase in Canada. But to me, how you think about things makes a massive difference in terms of what you practically do. And I would say that if you embrace this framework, I would guess it's likely that you will start taking a very different set of actions for safety. So it's not in itself, as I said, a tool for improvement or a framework for improvement in the way that, you know, a breakthrough collaborative is a model for getting improvements, or at least for structuring the way you go about them, or a PDSA cycle is a technique for testing things out. It's not of that nature. It's much more like, for instance, the framework that we developed, or other frameworks that for thinking about how things go wrong, about the contributory factors involved in an incident. If you have a really clear framework in your mind, it'll help you structure your thinking, and I think it'll lead to good places. I think that Virginia was another aspect of this question, which I've forgotten in the course of conversation.
The burning platform for adopting the framework.
Burning platform, well, I think I'll put that back to you. For me, it was complete confusion. That's enough to stimulate my interest. And the burning platform for me is just the naivety and the sometimes stupidity of the way safety is approached in healthcare, and the sense of dissatisfaction that we're not grasping what we need to, and we're not looking at the important things. But I think it's not for me to give you a burning platform. It's your own assessment of the situation you find yourself in, or we all find ourselves in, personally in our understanding of safety, whether we are satisfied with how we understand it, and in our organizations. So it's a question for each of us, I think.
Thank you. Ross, would you like to speak to that at all, about the burning platform? Is Ross muted?
Yeah, Ginny, I would say that just agreeing with Charles is that really your interest in this really depends on how well you think your organization is doing in safety, and how you think this has worked out over the last several years and moving forward. And many organizations, I think, feel that their focus has shifted to financial issues or other issues of access, and it's become difficult to maintain a focus on safety. And I think the beauty of this framework is it helps to structure a way for frontline teams to think about safety integrated into their daily work and building on their understanding of what's worked for us in the past and what hasn't worked for us in the past. So this is a platform that gives an opportunity to broaden the way in which we think about safety, and to really give staff an opportunity to become more deeply engaged with this as a way in which they structure their daily work. And then similarly at a board level, it becomes a way to think about safety that isn't just a series of metrics that are divorced from other aspects of organizational performance. So it's really, as Charles says, it depends on what the appetite is to really engage this. It's a very useful framework, but it requires some investment in thinking about what does this look like in a particular service or a particular organization.
Thanks, Ross. I think we're really out of time now. I'm going to ask Chris to just close this off, and Alex will put up the poll. If everybody could take a few minutes just to answer the few questions we have. Thanks.
Well, thanks, Virginia, and I just want to give a huge thanks to Charles and Ross for your wisdom and your knowledge, and for really introducing us to this framework. For me, the burning platform is we are still harming people at an alarming rate in this country, and we don't have a good sense of what that is, and a lot of how to prevent it in many organizations. So I think this was a great start, certainly for me. And I do want to thank everyone for coming on the call and your interest. This call sold out very quickly, and we had a lot of disappointed people who couldn't join us, so hopefully it was well worth your time. This is the first of a three-part series of calls about the framework. As we're really proud at CPSI to announce that we're investing in bringing the framework to the Canadian health system context through funding a research project with Ross and his team, providing measurement coaching, facilitating cross-sectoral learning, and communicating our findings. So stay tuned to CPSI for more information about the upcoming webinars and all the work that we'll be doing on this framework.
Thank you very much, Chris. On the screen, you'll see links to other information about the framework, about accessing the recording of the call, and about Shift to Safety. If you want to learn more about Ross's project, please contact me as you see listed on the screen, and I will get back to you. So, did you get the poll up, Alex? Sorry, Alex is having trouble getting the poll open. But I think it is, no, sorry, we can't get the poll open. So thank you everybody for attending, and we are planning our next call about implementing the framework at the front line for the 23rd of February. Looking forward to having you on that call, which will be really interesting as well.